community hospitals in Ontario are threatened by secretive attempt to expand private surgical clinics in province. Ontario's provincial government is making a substantive change to how some surgeries, procedures, and other ambulatory health services now available through public hospitals will be provided in the future. It appears that the province is purposely doing very little to ensure the public is aware of the regulatory changes that will expand the use of private clinics to deliver publicly funded health services. In fact, the consultation process is so low-key and under the radar that it seems like the province really doesn't want public scrutiny. The doctors lobbied to move surgical and diagnostics work from the hospitals. The government let the emerging industry slip free of public reporting and oversight. The province does acknowledge that these changes would allow surgeries, procedures, and other services to be shifted from community hospitals to private clinics. Already the government is closing down community hospitals. By moving core work over to private clinics, this threat is deepened. Clinics will obviously only seek to provide services where they can make money. Instead of providing a range of services, community hospitals will see more and more services creamed off, leaving them with the most difficult and least profitable. The Ontario government recently announced a plan of closing hospitals in the Niagara region. The government is planning to close 5 out of 7 hospitals. This is giving us a very clear idea of where all the services from those 5 hospitals will move. This backdoor change, combined with the government's move to centralize hospital services, threatens the long-term viability of community hospitals across the province.
The government is trying to introduce United States-style system. Despite the fact that there were so many issues and concerns with this kind of system in the United States. Considering that the United States Congress stopped construction of specialty hospitals for several years in the last decade over fears that they were draining profits from full-service hospitals. New York Times article suggests that the small hospital movement is about doctors getting back in control. Surgical clinics could be an expanding business for them. United States Congress was also concerned about the ability of private clinics to handle a medical emergency.
Recently in Texas, where a 44-year-old man named Steve Spivey developed breathing problems after spine surgery. No physician was working there when the staff first recognized he was in trouble. They phoned 911, and he was taken to a nearby full-service hospital, where he was pronounced dead a short time later. The episode occurred at a small hospital that is owned and run by doctors, one of roughly 140 such hospitals around the country, with nearly 24 more under development, that are set up to specialize in certain types of procedures like heart surgery, back operations, and hip replacements. These hospitals have been assailed for cherry-picking the most profitable procedures from the nation's 4,500 or so full-service hospitals. Critics have argued that the doctors have a financial incentive in sending patients to their own facilities, even when those patients might be better off having their surgery in regular hospitals. A similar case involved an 88-year-old woman 2 years ago at a small doctor-owned hospital in Portland, Oregon, where the nurses called 911 after she was given too much pain medicine following spine surgery. She too later died. A systematic review and meta-analysis compared death rates in over 500,000 adult patients receiving care in either for-profit or not-for-profit American dialysis facilities. The study found an 8% greater risk of dying in a for-profit facility. The results were extremely consistent across all the studies surveyed. They showed that if American patients received care in private not-for-profit dialysis facilities instead of for-profit facilities, approximately 2,500 lives would be saved each year. The results of this review are relevant to over 12,000 Canadians receiving dialysis. First, the studies included patients receiving publicly financed care in private not-for-profit and private for-profit dialysis facilities, a situation identical to what Canadian policymakers have been considering. Second, the results are consistent over time, despite changes in American health care. Third, if Canada moved to for-profit dialysis facilities, the same large American dialysis chains included in the review would likely be purchasing Canadian dialysis facilities. Another recent meta-analysis study found that hospital deaths would increase by as many as 2,200 a year if Canada introduced United States-style private for-profit hospitals into the healthcare system. The studies included data on 38 million patients in 26,000 United States hospitals between 1982 and 1995. The death rate in for-profit hospitals was 2% higher than in not-for-profit facilities. A third meta-analysis of United States for-profit care concluded private for-profit hospitals result in higher payments for care than private not-for-profit hospitals. Evidence strongly supports a policy of not-for-profit healthcare delivery at the hospital level. The study found that care cost the patients 19% more at for-profit hospitals. Canadian governments would pay an extra $7.2 billion in annual healthcare costs if Canada switched to investor-owned private for-profit hospitals. The meta-analysis used 8 observational studies, involving more than 350,000 patients between 1980 and 1995. The studies had a median number of 324 hospitals.
The death rate in United States for-profit hospitals was 2% higher than in not-for-profit facilities. Typically, investors expect a 10% to 15% return on their investment. Administrative officers of private for-profit institutions receive rewards for achieving or exceeding the anticipated profit margin. Also, administrative officers of private for-profit institutions will try to save money, cut the cost, and increase profits in every possible area. In some cases, improper cleaning products were used or diluted to a level that cleaning and disinfection were not effective. Also, to lower the cost, clinics were hiring staff with questionable qualifications, knowledge and skill levels. The doctors lobbied to move surgical and diagnostics work from the hospitals. The government let the emerging industry slip free of public reporting and oversight. Subsequently, after a death and a coroner's report, the government required the industry to face some modest oversight in 2010, not by a public authority, but through self-regulation by the docs. Remember, the doctors had lobbied to expand the industry in the first place. Then in the fall of 2011, following disclosure that 6,800 patients would have to be notified that faulty infection control procedures at a private clinic could have exposed them to HIV or hepatitis, Health Minister Deb Matthews declined to introduce oversight by a public authority, despite public pressure. Instead, she comments, "Government can't do everything. A professional regulating body like the College of Physicians and Surgeons, they take responsibility for their members."
Eventually, the College of Physicians and Surgeons releases a report on the private clinics that mentions that some 29% of the private clinics fall short in some way. But the college won't tell us which ones or how they fell short. This is taking the responsibility seriously, it seems.
Notably, the college is so distant from public control and so oblivious to public opinion, that the report is heartily self-congratulating. They were, it seems, expecting accolades.
Now the minister promises she will improve the public accounting by the physicians and surgeons, although exactly how remains unclear. Will we ever find out the clinics that fell short, but did not outright fail? Or how they fell short? Will we receive annual public reports? The underlying problem is that public disclosure runs contrary to the interests of private providers, not just in the clinic business, but everywhere privatization appears in healthcare. It reveals secrets to competitors and problems to the public. Both threaten the ability of investors to remain in business, making profits. Lurking only slightly below the surface in the recent fight over changes to funding for physiotherapy is yet another problem with healthcare privatization. The government is stopping the ability of 94 physiotherapy clinics to directly bill Ontario Health Insurance Plan. Ontario Health Minister Deb Matthews says that, over the years, licenses to provide these services have been bought up by large corporations. Currently, 2/3 of the billing goes to 4 companies that are, she says, behind the protests against her reforms.
And that is a widespread problem with privatization. In the United States, the center of private healthcare, corporations are regularly accused of gaming the system and overbilling, sometimes taking the public for billions of dollars. We have had quite a run of healthcare privatization scandals in Ontario. eHealth, Orange, chemotherapy mixtures, the Brampton P3 Hospital. But the Ontario government just keeps trying to privatize, despite the results.
Ostensibly, the government's policy is to integrate healthcare, but the introduction of clinics goes exactly in the opposite direction. Instead of cooperation, sharing of best practices and integration, we are getting commercial secrecy and fragmentation of providers. Please get involved and support the Ontario Health Coalition in the battle against private clinics. Surgical and diagnostic services belong to community hospitals with highly controlled standards, proper policies and procedures, properly trained staff and the ability to deal with emergency situations. Surgical and diagnostic services shouldn't be in private clinics that only look at how to maximize profits.